shall now go on to our next speaker, Dr. Vikas Mittal, with a 16 years experience in cornea and refractive surgeries, who is the director of LJI Institute, a very capable prolific surgeon, and he is going to be talking on manual dissection in DALT. On to you, doctor. Can you share your screen?
Yeah, I'll just share. Is it visible?
Yes.
Okay, fine. Thanks so much, first of all, Dr. Chitra and whole ARC team for this kind invitation. There was a beautiful talk on FALK, so we were in anterior stroma. So now I'll go if there's a region which is, deeper stroma, or where we'll do a DALK. And my job is to tell you how we perform a manual dissection DLK. And for this, I'll just take you through how I have learned this and how I generally perform it. For manual DLK, you cannot have any financial interest. So I started doing DLK close to 15 years back after my fellowship, and my first 6 DLK were 100% failure. So all 6 DLK I had to convert into penetrating keratoplasty. So at that time, I thought that maybe, I'm not a very good surgeon, or maybe this is not my technique. And I thought maybe then I started even trying to convince myself that PK is even better. I started telling myself that, if keratoconus, dystrophies, PK has very good results. So maybe I should do only PK. I shouldn't do DLK at all. And then I visited Baroda to Dr. Paras Ben Mehta and stayed there for a day in her clinics. And there I told her, Madam, see, the DSEC is easier than DLK. That's what I told her. And she said, no, Vikas, you can do it. You can definitely do it. And she showed me a few of her cases. And she says, you can do it. The only thing you have to do is get this bubble out of your mind. So the DALK can also be done without bubble. And then when I came back and started doing my manual DLK, where she suggested me that it's okay to leave 70-80 microns of posterior stroma behind, and you can go ahead with your routine DLK. And then I started seeing my DLK post-op, which was quite exciting. Although in the first couple of days, it was looking a bit hazy, but once this 1 month or later on, it was absolutely pristine. And I was feeling very good that, actually I can do a DLK. And with time, we started doing a large diameter or even PMCDs, advanced K-corners, keratoglobus, and there was no need for a backup tissue. Initially, my DLK always I used to have a backup tissue. So here there was no need for DLK. And if you tell your patient DLK, I was sure that I'm going to do DLK only. So there was no reason that I have to explain that, maybe I'll have to convert it into PK. And there was no fear of perforation, as I said. And then there was no specific instrumentation that was needed. And that's why I think even now I'm continuing my manual DLK. And there's a recent publication from Dr. Fogla and Dr. Namta Sharma, and close to 1/3 of cornea surgeon in India or CSI members, they do manual DLK. So I think I'm one of those 1/3 surgeons. And why do they generally do it? If you see biomechanics in DLK, whether you do a big bubble or whether you do a manual lamellar dissection, it's same. And the visual results also, the astigmatism, best corrected visual acuity, once the switch is out, or 1 month later on, endothelial cell count, it's comparable, it's same. And in case you get into some problem, if you get to have a full thickness definition, the manual dissection DLK will be a big rescue. This is a beautiful beautiful review that I came across, who had reviewed all the techniques of DLK, and these are the complications that have been mentioned. And you know what? With manual DLK, there are no such complications that are possible. Emphysema, double bubble, perforation, double AC, these are almost rare with DLK. So majority of complications that has been described in literature are not possible with manual DLK. So what I'm going to do is I'm going to show you a video of how I generally perform the manual DLK, so that you can get a okay. So this surgery was done in a patient of keratoconus. So the surgery will be into 3 steps. First is host bed preparation, graft preparation, and then suturing. Let's take first host bed preparation. You need to choose a trephine size so that you can include all the cone, Fleischer ring and topography map can guide you. So it is important, even if you take a larger diameter, it's absolutely fine. Flaringa ring, I like generally using Flaringa ring in all my keratoconus patients, but it's an optional step. The refine, it's very important to just make an impression. So if in keratoconus you keep refining and make a groove, then sometimes what happens is you end up cutting more of posterior stroma than anterior stroma. So you can have a not a straight cut. So what I generally do is just make an impression, so that we know that what is the area that I'm going to dissect. And the grooving is done with a prefixed guarded blade. And here I'm using 250 microns. What I generally do is choose your thinnest pachymetry, subtract 100 microns from that, and that you can use 250, 300, whatever. So here there is a 360 groove, and the angle will be perpendicular to this area. So your blade will not be perpendicular to the visual axis, but perpendicular to the where your impression is, so that you can have a really straight cut. Once your groove is done 360 degree, you can catch hold of this anterior stroma and dissect it off. This is similar to what we do in any DLK technique. Here you can be very fast because it's quite thick and not very difficult. Important thing is to catch hold of the tissue flap near to the attachment and then cut the fibers which are attached to the flap. This will be more important when we are cutting in second and third layer. So once the first layer is out, you make a decompression, and this air bubble, this fluid on the stroma and a dilated pupil, this helps a lot in seeing how much stroma is left over. So this is the layer number 2. Generally, you need to remove 3 layers. In 3 layers, most of the stroma is out. So here you catch hold of the thicker area. I generally like this upper and superior, this area, and then you first make you start dissecting all through, and then here you need to be slow. And what I'm trying to tell you is this: catch hold near the stoma and cut these fibers which are attached to the the flap, not the stromal bed. If you pull it, so you should not pull. You just simply need to just have a small pull, very and then cut these fibers which are attached to the flap, so that the chance of perforation are minimal. Again, a fluid drop will tell you how much stroma is left over. So this is the third or the last layer most of the times. And when you are reached the posterior stroma, you can actually peel off these fibers. So you don't even need to, cut, but you need to be careful. You need to be slow. And you can see here, these fibers can be easily peeled off. So that means that you are nearly in the posterior stroma. Again, you can place a fluid and drop, and you can have an idea how much stroma. So this is my host bed is prepared. So next would be preparation of your graft. Graft preparation is, you can choose the disparity. Generally it's 0.25, but if it is advanced keratoconus, large define, it's okay to use same size donor as well as graft. So you can punch the graft first and then you remove DM, as is done in this case. You can use a Merosol sponge. And if this tissue is old age tissue, the removal of DM is very easy. But if it's in a young patient, tissue, then sometimes it comes in a piecemeal. But it is important to remove all the DM and any epithelium, as you can see here. You can remove the DM first and then punch also. So in this case, you can remove the DM the way you do it in your DMAT. So you can punch anytime. So next would be the last step would be suturing. Pattern of suturing, you can choose whatever suture is. Suturing technique works well best in your hands. I like interrupted sutures, so I'm using 10 nylon. I'll make 16 interrupted sutures. Here the difference from penetrating keratoplasty suturing and DLK is, here I'm not going to keep 90% depth in the donor, so I'll take 50% depth in donor and are close to 70-80% in the host tissue. So it's important that you be aware that there is a DM down there, and you can you can puncture if you are not very careful. Suturing is very important step, because the astigmatism and all those astigmatism will be mainly done by these good suturing. So here what I'm doing is pushing these folds into the periphery. I generally start doing this massage after 8 sutures. So from the center to the periphery, so most of the folds that are because of the excess stroma, so that gets pushed off into the periphery. So the sutures are buried in the graft. and then you just have a look with your Melanese ring to ensure that you get a good circle, as you can see here, and then the surgery is over. Remove your flaring ring, place a bandage contact lens, and that's it. So this is how generally looks first POD looks like. And you can see the first post-operative day, 77 microns, 42 microns. So it hardly matters if you have 42 of 70, because 77 microns, because once 2 or 3 months down the lane, you can hardly see your remaining tissue. So there has been a few publications where penetrating keratoplasty has shown a better visual outcome, and it's mainly because if you leave thicker stroma in that residual tissue. But if it's very less, then it hardly matters. But once all sutures are out, it's very difficult to see where your residual stroma is. So you can see 1 year, 2 years down the lane. So overall, so no need for backup tissue. DLK means DLK, no perforation, no special instrumentation is needed. So actually bubble got out of my mind, and even after 15 years, I'm still following my manual DLK. Thank you so much.
Thank you very much, Doctor. That was an amazing talk to hear and very practical tips. I just have one question to ask before I hand you over to Dr. Rajesh Fogla for more discussions. If you've had an unsatisfactory BCVA post-DAL, how long would you actually wait before you decide to convert to PK?
So that depends that what is the reason for unsatisfactory visual outcome. So most of the time, unsatisfactory visual outcome is because of the astigmatism. So if that you need to address why that astigmatism is more, whether it's a sutures problem. So you can have the intraocular suture is very good, that you can later on also you can remove your sutures. Generally, if you get a really weird astigmatism within first month, it's better to remove those sutures and place a new sutures. Otherwise, your routine astigmatism management that we start after 3 months. So most of the time it is because of sutures. So I haven't seen any patient where the visual outcome is less because of the interface and interface haze. There was a couple of patients, I think, where you have a bad surface and you have to do DLK for some other reason. There you can get an interface vessels. That is the only area where you might have to think of doing converting into PK. But again, those will be very high risk grafts, and you need to take care of immunosuppression as well.
Dr. Rajesh Fogla.
Yeah, Vikas, nice presentation. From what I understand, you indicate that you are not doing any more big bubble DALs.
That's right. I don't do any big bubble DAL at all.
Yeah, but that I think is again a little extreme, because selective cases, big bubble DAL definitely gives a better visual outcome, both in the terms of the rate of visual recovery and the number of percentage of patients achieving 20/20 or more. And if you select, at least in my practice, I rely more on the anterior segment OCT. And any cases where the pathology is involving the predecimus layer or the decimus like a scar, then I avoid any stromal injection of air, because that is going to have an abnormal outcome of the air injection. And in such cases, doing a manual DAL definitely is recommended. And in your surgical video, you were doing all your dissection using the same sharp crescent, or do you modify the instrumentation?
Yeah. So generally the first, second and third layer will be a blunt crescent, a used crescent, and the first will be the same, the prefix depth and the same one. And if I have seen my big bubbles, the initial ones, and the manual DL, somehow I found that if you have these 50-60 odd microns stroma left over, you can't even make out even in the OCT later on. So I think the main difference in visual acuity would be in the first month, or maybe first 2-3 months. But later on, what I have found is it's same. But I agree, the big bubble DLK is also extremely good technique.
Yes, because I think the key point that you made was having a residual bed which is going up to 60-70 microns. But for somebody starting out with DALK surgery, how does one, recognize that they have only 60-70 microns, unlike you have an intra-op OCT like what Dr. Namrata has? It may be sometimes a little difficult. So what are the tips on recognizing? Is it just multiple layers of dissection, or is there anything else that you would want to?
So what I generally, we don't do any intraoperative pachymetry. So as I said, if you have a dilated pupil and you place a drop of fluid, So you get a hang of it, that how much stroma is left over. And in case your central part is, around 50-60 microns, and in the periphery, even if you have a thicker one, it hardly matters. So it's the central part, but what I found is more important. And how do I see how much thickness of I have reached that thickness is just after doing got a hang of it, that how much stroma is left over. And then, as I said, that if you start reach a layer where you can easily peel off these fibers, so that means that you are already in possession.
Can I just make a comment here, Chitra? I think when we didn't have intraopposite microscope, we did describe, and Dr. Vajpayee described a technique of diamond blade assisted deep anterior lamellar keratoplasty. So if you have that, then you can actually do a intraop pachymetry without having a OCT microscope, just a ultrasonic pachymetry intraop at the level where you're going to dissect, and preset your diamond blade to minus 80 microns. And what Vikas is saying and what Rajesh also says is perfectly correct, because there is a paper, if you see, almost 5 to 6 years ago, which has compared DALC, where the residual bed thickness was to the tune of 80 microns versus DALC, which was just desmetic. And they said that if you leave 60 to 80 microns thickness, it really doesn't make too much of a difference in terms of visual acuity or in terms of contrast. Although today probably we will not go by that, and still we will tend to think that if it is desmetic, then the best corrected visual acuity and the contrast sensitivities are going to be good. So I think if you have a diamond blade, then you can always preset to that and make a groove, and then try and get that thing. Although I do believe that in keratoconic corneas or extreme ectasias, it will be a difficult thing to do, to get that same level over that bulge which is there.
Sometimes you tend to have at the apex, especially in keratoconic corneas, you will find that at the apex or at the thinnest point, you are down to about 30-35 microns. But if you go to the periphery, you will find that you still have 100-110 microns remaining. So the question then comes is the graft-host junction apposition. So if you're taking a full thickness donor and opposing it, while the sutures are in place, the graft-host junction looks quite flat. But once you remove the sutures, you have a kind of bulge at the graft-host junction in the periphery, which then kind of induces aberration. And often you find that in such patients, once you do all the suture removal, often there is a drop in their quality of vision because of this change in the corneal topography. So for that, I think Massimo Bucin has shown a technique where they use the anterior cap from the DSEC surgery. So their grafts are only 400 microns in thickness. And for manual DALC, they place the 400 micron, and that gives a better apposition of the graft-host junction.